think I'm the exciting end of the entertainment, perhaps. Our organisation's been a rural organisation for the last 20-something years and supporting general practice and allied health. We saw this program, and thank you to the Queensland Regional Training Networks, state funding, Health Workforce Australia, for the opportunity to do this. But for us, it was a chance to build on the journey that we'd already started and to really look at trying to improve access to healthcare services for rural communities. So where did we start? Our key area was engagement with training providers. We thought that would be easy. Very naive, my rose-coloured glasses on again. Universities are a disaster area in communication. Where do we start? We started at the top. Let's go and talk to the deans. All very excited, very enthusiastic. Yes, we'll place students rurally. Nothing happened. So let's go down a level. Let's talk to the lecturers. Nothing happened. I've actually met 2 student coordinators here today who we couldn't find. So there was some success though. You know, it's just today's an opportunity to put forward the perspective of organisations who are passionate about taking rural students and placing them and showing them the work that needs to be done and the potential that they have for careers working in the bush. And we contacted all of those universities. The turf war between universities just drives me insane. You know, places can take students from 2 universities. The fact that Bond University doesn't even have a rural medical placement program, you know, and the students want to do it. It's not the students, we just need to fix the system so that it can happen. We had, just by luck, a rural health club weekend in Emerald. And we thought, oh, we'll go and talk to the rural students and see what happens. And we took a sign-on sheet. The table was mobbed. We had to go and get more paper, more sign-ons, more addresses. The young adults, and I keep calling them kids and that shows my age, not theirs, were passionate. They wanted to come out and work rurally. They were excited about the opportunity to do different things, and they were excited about the chance to make a difference for people. And we need to value that when we're training people and when we're giving them the chance to come out and do that. So we followed them up. And then somebody younger than me designed the Facebook page, which was just an amazing hit. We were getting student contacts from Victoria, from New South Wales, from the Territory, wanting to do placements. And the majority of them, we could actually find a place for them. They were happy to fund their own travel, they knew family there was a reason they wanted to come. Or they just wanted the chance to do a rural placement and they couldn't get a rural placement anywhere else, so they were coming to us. It was amazing, it was refreshing. I didn't do that. Oh, very good. Some of the actual real barriers that we found: the insurance. To take a student on placement, they need to have professional indemnity insurance to be placed. Where their university was supportive, their clinical placement providers could actually organise that for them, whether it was a university placement or it was a holiday placement or they were doing something, you know, innovative off their own bat and going rural. Good on you. But there were a lot of universities that couldn't organise it. We've now found that Aon Insurance actually will do it privately and the students will pay for it themselves. And they're happy to do that. Some of the aged care placements, because we did integrated placements, police checks became a problem. If your university doesn't do that, the kids can do it themselves. I've talked about internal communication. Some barriers for university placements in the rural communities is that they felt the population sizes were too small and the students would benefit from the placement. I would not hesitate to disagree. I think that there is plenty of potential to learn from one patient. Suitable accommodation is an issue, and like the previous speaker, we went to the community and looked for homestay. We didn't offer them any money. We said to them, if you want healthcare, you need to get the students out here and we need your help. And they were more than happy to do it. 2 people have renovated granny flats, particularly to take students. They enjoy, a lot of them had children that had grown up and gone to university, and they enjoyed their company. They wanted to be part of that whole university process and support them. And I think that's an aspect that we could really, really develop in rural communities. Rural placements are not a priority. It is for us. It is for the people that live in rural communities. It is for those of us that need healthcare. We need to speak up and make it a priority for everybody. CQU is our closest university. A lot of their programs are not ready. We're not ready for placements. They are now, and we will continue to try and build those relationships. And there's a mountain range west of that regional centre, and just getting people to get over it would be really good. The other thing is working the staff changes and having a position-to-position relationship rather than a person-to-person relationship, because all of these placements need relationships. The students need to have relationships, and we need to have relationships. The model for student placements. We got a group of us together and said, what does rural really offer? What can you learn in a rural setting that you can't learn in a traditional urban-based setting? What do we have that the others don't? Senior clinicians, everybody we went to and said, are you happy to take a student, said yes. Some of them had a few questions like, what do you want me to teach them? But they were all happy to take students, overworked, stressed, but if it meant that there's a future workforce, yes, we'll deal with the students. What was there was the opportunity for multidisciplinary placements. Yes, you can place med students in general practice, but we can also place them in the hospital. We can send them to the aged care facility. They can work with QAS. They can go out to the gem fields and see how people live in various ways. But it works the other way too. We can put nursing placements in general practice in aged care. We can work with allied health. They can work with community nurses. They can work with hospital. They can work with aged care. We can put people in pharmacies and understand how pharmacies work. And because in a smaller area, you're a network. Everybody knows everybody else anyway, and we all talk to each other, well, nicely most of the time. And so it was actually quite easy to work out those placements. We picked up a lot of students from voluntary placements during breaks. We got the community involved. People went on mine tours, they went mustering, they had a look at the towns. One of the other things that we found we had to do was work out how to do a placement plan for the students and for the supervisors. You would contact the students and ask them, what are you meant to achieve on your placement? What do you want to learn? Well, I don't know, we have to do a placement. You should talk to the supervisors, and they would say, what do you want to teach them? So we'd actually have to feed that process. Would you like to work in an Aboriginal community? Oh yeah, that'd be great. Would you like to work at the hospital? Yeah, that'd be brilliant. And it's that planning of the placement to maximise what's there in that community that makes the difference. But it was so hard to get the university end and the supervisor end through the student to talk to each other. or to talk to the student. We've had students turn up and their supervisor's been on holidays. They've had no accommodation. And so people know us and go, well, you know, what can you do? And I've had 2 students now stay with me, cope with the animals and all of the dramas, but that's all right. Sorry, I'm just going to flick through the numbers. 25 placements, 25 requests. We placed 18 students, all different disciplines. Moranbah does a great job with medical students, and they've recruited from that. These are students that we placed in areas that we really weren't targeting because people were contacting us to do that placement, and I think that's one of the key learnings, is to have people with relationships with universities in locations that can support that placement. High points, we actually got funded for an ACRM, the Rural and Remote College of Medicine house, 15 years ago or so now. We still have that house. We just keep it full. And people are staying. The future, maintaining that coordinator position. We're going to self-fund, lobbying, collaborative arrangements. We all need to work together. The problem's too big for one organisation. Placement plans we have to work on. We're doing a supervisors training update, brief to the point for senior clinicians. The other thing that I want to beg quick time to finish is to plead with you all who have any influence on training to look at innovation, to look at the iTunes picture, because telehealth is out there for every discipline and every resident of a rural community, and it is not being used. People think that they have to sit next to the patient to be able to talk to them. They don't. Families communicate with each other over Skype all the time. It's fine. You can love your grandchild over Skype. You can talk to your OT over Skype. You can, you know, you need to go for the appointments, but we need the students to lift that level of thinking to say, okay, for your next consultation, and I know it's not Medicare billable and we have to argue that point, but for those of organisations that are funded, we need to use the technology. Thank you. Sorry.